a todos. Algunos os conozco, a otros no. Yo me presento, yo soy Nuria Puente, soy internista de aquí del hospital y trabajo en la unidad de enfermedades raras de adultos de aquí del hospital. Hoy tenemos el privilegio de tener con nosotros a la doctora Stepien. Bueno, lo voy a decir en inglés. Va a dar la charla en inglés, trabaja en Manchester. With us today, she's a clinical consultant in Salford, in Manchester, and she's an endocrinologist and she's an expert in inherited metabolic diseases in adults, and also in the transition from pediatric to adult care. Dr. Stepien, she's the principal investigator of numerous academic and commercial studies, and her research aims to understand the natural history and the progression of inherited metabolic diseases, as well as long-term outcomes in adults. I had the pleasure of spending and learning from her over 6 months, and I would like to say that not only does she have a brilliant professional career, but also she's a great person. So please, Karolina.
Thank you very much, Nuria, for your kind introduction. And thank you very much to you all for attending this small presentation today. It's a great pleasure to be here and to share our experience. Hopefully, after the presentation, we can have a fruitful discussion. So, as Nuria said, I work in adult inherited metabolic diseases in Salford, in Greater Manchester. We are one of 5 tertiary metabolic centres in the country, and we look after over 2,300 adult patients with rare metabolic diseases from the age of 16 to the age of 80. Today, I would like to give an overview of this specialty, but also and about challenges and opportunities we're going to discuss. We are coming across in our clinical practice. We'll touch on transition, and I understand it's quite relevant to your clinical practice, and I'll present some late onset and late diagnosed cases from our clinical practice. So you might have seen in the social media and recently in the GMD, one of the recent publication by the Adult Metabolic SSIM group, that the number of adult patients with rare diseases has grown exponentially over the last few years. And it's been estimated that 40% of patients are diagnosed in adulthood, which is quite relevant. So we know that there are cases presenting with more severe forms in childhood, and they require multidisciplinary teams care. They have very complex presentation, and then they may transition over to the adult services for a longer follow-up. But there's a proportion of patients, and it's estimated by different sources, 35 to 50%, who may present for the first time in adulthood. And we have easier and better access to genomic and newborn screening, and we know that, again, it is being introduced in various centers, various countries. So it will identify children, infants affected with these rare conditions, but also patients who are asymptomatic, patients who may develop symptoms later in their life. And there are obviously ethical dilemmas around that, because some patients may not want to know they are obviously affected with a particular pathogenic variant, and they don't want to know whether they are going to have symptoms at the age of 50 or 60. We can discuss it later on. But all these patients have complex clinical needs, and as a result, they develop complications related to the rare metabolic condition, but also complications related to their age. I'll present some cases later on where patients might have had some subtle symptoms and it was not clear whether it was related to their condition or their age. And there's a need for adult metabolic clinicians who would be able to follow up these patients long term. There's a need for better funding, guidelines, better excellent institutions like yourself to follow up these patients long term. And this is only an example from a small review of Fabry patients from a few years back, where we reviewed the referral pathway of Fabry patients. So, as you would expect, most of them comes from clinical genetics. It's an X-linked condition. So, once one person is identified with cardiomyopathy, arrhythmias, possible fainting episodes as a result of arrhythmias, then it triggers a family screening. And we may have 16 to 20 referrals coming to us at the same time. But also general practitioners, and you would wonder who are these patients coming from general practitioners. These may be patients with TMAU, trimethylaminiuria, patients who are Googling their own diagnosis on the internet. But this may also be patients who were lost in follow-up. They were going through the pediatric metabolic service and they were under their care. Then they were lost in follow-up, or they disengaged with the adult services. And only when their symptoms became more pronounced, they asked for a rare referral. So general practitioners referred them to us. Obviously, it's relevant for Fabry patients, a cardiac genetic nurse, and transition. 11 patients of Fabry only come from transition services, and obviously cardiology, renal medicine, stroke, depending on the clinical presentation in their adult life. So, what's the transition? Actually, it's one of my special interests. Transition is a process. It's a process of preparing a younger person to be independent, to have their own autonomy, to know how to self-direct their care. And in the clinic, once we see them initially in the transition clinic, we try to speak to the young adult, not to the parents. So the transition clinic is often held at the Willink unit in Manchester, where the adult team with a dietitian, a nurse, physiotherapist, a clinician is attending. So obviously there's a large room and there's a pediatric team. So it can be quite intimidating for young adults to attend such a clinic, but we try to speak to the patient, while pediatricians, they may still speak to the parent. And the transition is a process. We see these patients every 12 months. They are getting used to us, getting used to the idea of being transferred, having the care transferred to the adult services. And the transition, it doesn't finish at the time of the transfer. Transition still lasts when we see them in the adult care, and once their care is fully integrated in the adult metabolic services, they are not missing any appointments, they are fully responsible for renewing the prescriptions, they are contacting us for results such as for PKU, for example, and they are engaging more in terms of their care and not their parents. Then we know that it's the end of the transition and the transfer of care has been completed. So the graph on the left-hand side, it just shows that apart from the Willink unit, we also have a transition clinic in Bradford, which is the outreach clinic. And also our team has to go there, or during the COVID pandemic, we utilized telemedicine more. There's also a transition clinic ad hoc with Birmingham, often held remotely, and we have a transition clinic with Alderhay in Liverpool. And this clinic is there's a slightly different setup, because pediatrician with the patient, with the family, and his pediatric nurse, they come over to us, to Salford. And this is to have a formal handover and also to show the young adult around the hospital so that they know where to attend next time. And the graph on the right-hand side, it just shows how the numbers have increased exponentially over the last few years. The last one, 2021, is slightly lower because it coincided with the COVID pandemic. But we know that there will be more and more younger people coming to the adult services, so there's a need for adult metabolic clinicians, because more patients will be diagnosed by genetic testing in the next few years, and also the genomic newborn screening. And so our data, our clinical practice is in keeping with the data from EU. So I'm part of the transition working group within MetaBERN, and only in 2017, 1/3 of all patients from 69 countries who provided the data, they were adults, whereas only 2 years later, the numbers, the proportion of adult patients was comparable to the pediatric group. And this is from one of our previous publications on transition strategy. You may be well aware of that, because I understand you have very individualized transition clinic already here, but transition lasts over the period of 18 months, 2 years. The more complex case, the sooner patients should be seen in the transition clinic. Often they are seen by nurses in the adolescent clinic, and this is to kind of have one-to-one interaction with the young adult, and if need be with the parent, but also to understand what the main challenge is. And also this is the time for a young person to be taught about the metabolic condition, and to know what the main problem is before they start attending transition clinic. So during this process, they have the opportunity to meet us, they have the opportunity to ask questions, but also our transition coordinator is completing the relevant questionnaires to evaluate their readiness, so it's ready, steady, go, and there are various proformas, and we as an adult team, we tell them what information is required for the transfer of care to the adult services. But one of the challenges is obviously young adults are disengaging with the adult services. So they may be fine during the last transition clinic, and we say in 4 to 6 months we'll see you at Salford, and they never turn up. They never pick up the phone, they never turn up, they feel they are young adults, they are fully independent, they fully know what they are doing, and they just don't feel to be, they don't feel the need to be engaging with the adult services. Unless something happens, unless they need application support with the application for some benefits, financial support, or if a young PKU, a female patient is pregnant, so then they kind of engage back with us. So, but this only reflects the lack of engagement of young people during the transition services. They didn't fully understood, they didn't fully understand the need for the transition, the need for education. They had no interest in this condition. They just became young adults, and they felt they are completely well, and they were in denial that there's anything wrong with them. Now, I would like to move on to the late diagnosis and delayed diagnosis. So we know that diagnostic delay in rare diseases is a problem and has an impact on the patient, on their families, and the society as a whole. And it's estimated that on average, in some cases, a diagnosis is delayed by 4 to 5 years, but we know from the literature that it may take over a decade. And there are families where they are attending appointments in various clinics, institutions, undergoing repeatedly investigations and before the diagnosis is correctly made in them. So it's worth emphasizing that delayed diagnosis is when a young person is manifesting symptoms, often complex symptoms, for a longer period of time before they are seen by the right person, before somebody considers the right test, and the diagnosis is made. Whereas late onset condition is when a person is completely well and suddenly something is triggering symptoms in their adult life. And it applies to OTC deficiency, but also may apply to, I'll show some examples, several other conditions. So there are certain precipitating factors such as stress, such as trauma, such as acute illness, but also in adult people, pregnancy, surgery, dehydration, prolonged fasting, and alcohol. So I would like to move on to one of the most interesting cases from the last few years. It was a 34-year-old female patient. There was no past medical history. She just got married. She was coming from consanguineous family. And in September 2018, she presented with sudden onset psychosis. There was no history of intoxication, no alcohol. It's a no-no in the family. So she was admitted to the local district general hospital, and she was seen by internists, general medicine doctors, but also neurologists for 2 weeks. She was initially suspected to have encephalitis. And when the antibody screen came back as negative, 2 weeks later they asked the metabolic team for advice. And on biochemistry, as you can see, her total homocysteine was sky high, but also plasma methionine was low and plasma MMA was very high. So what's the diagnosis? Correct. That's right. So the late onset cobalamin C deficiency diagnosis has been made, and while the genetic testing was pending, she was commenced on treatment, and she responded well to betaine, levocarnitine, folic acid. But because of her psychosis, she also required olanzapine treatment. So 2 weeks later, all her biochemistry normalized. She felt better in herself, her balance improved, but psychosis still persisted. And she was discharged from the hospital. She remained under the metabolic team's care for follow-up. In 2019, she informed us that she became pregnant, and her psychosis unfortunately persisted, which was quite a concern during pregnancy because of her ethnicity and background. We thought she would stop all the medications, including antipsychotics, which was a concern, and the health visitors were involved in her case. She had auditory hallucinations during pregnancy. She was frequently seen 1 per trimester with full metabolic workup. And when the baby was born, she had this blunted effect, no facial expression. She was not fully engaging with us in the clinic, and her mum had to look after the child for the subsequent 3 years. But coming back to the admission in 2018, her MRI scan showed white matter changes, and in 2021 we wanted to repeat the MRI scan to see whether the changes have improved with the treatment, but she declined the test. At that point, she had no neuropathy and no myopathy, although her balance has been slightly abnormal, and now 5 years after the initial presentation, she has peripheral neuropathy on the repeated newborn screening. So late onset cobalamin C, as you know, it's an autosomal recessive condition. The methylcobalamin and adenosine cobalamin cannot be synthesized, and the methylcobalamin is a cofactor for methionine synthase. So methylcobalamin is here, and it's a cofactor for methionine synthase. So as a result of methylcobalamin deficiency, methionine is low and homocysteine is high. There were some cases previously described in the literature. So these cases may present with more neurological presentation, with cognitive impairment, with neuropathy, myelopathy, psychosis like our patient. But there were also cases who presented with hemolytic uremic syndrome for the first time, and the renal failure. So they were diagnosed by the renal physicians. So this is just to emphasize that these cases may be out there in the general population. But I mentioned that we had more such cases, and this is only a few examples of patients who presented late in the life, and the presentation might have been sudden, like in a patient with SSADH who was well, who might have had reduced IQ, but it was not a concern. She had a partner, she had her job, and suddenly she presented with seizures, and it was believed that she was either intoxicated or illness, infection unmasked the condition. But we also had a case of Niemann-Pick B presenting in his late 50s with liver cirrhosis and ascites, and on 3 occasions acid sphingomyelinase was reduced. We were not sure whether it was genuinely reduced because of Niemann-Pick B or it was reduced because of underlying liver cirrhosis. And the initial NGS, new generation sequencing studies screening for common variants in pediatric patients was normal, but we had high index of suspicion, and we sent the samples to one of the genetic laboratories in Madrid, and the patient was found to be compound heterozygote for 2 variants, which since then have been reclassified as pathogenic. And we know that there's a need for better biomarkers. There's a need for better tests to monitor these patients, to screen them. We know that there are cases diagnosed by metabolomics and not just by genetic testing. And there's obviously still a lot unknown about the benefits of genomic newborn screening in terms of the adult metabolic medicine. But the future is at our doorstep. We have and will have better access to various apps, to AI software, and they will help identify these patients sooner. So you may be aware about the Gestalt-Matches study or a phase 2 gene, which proved to be useful in identifying certain features which are characteristic for rare diseases, but it's not certain whether they are very sensitive to identify late onset cases which may not have typical features for rare diseases. And the question is whether they should be treated or not. So there are late onset cases diagnosed by family screening, and they may have some abnormalities in their blood, but they are completely asymptomatic. So there's another dilemma. I would like to move on to another case. It was a girl born at term, and her birth weight was 2.6 kilograms. There were no concerns in childhood as such, until she required hernia surgery at the age of 3 years. She struggled with her speech in primary school, and later she was enrolled to a special needs school. She developed hearing problems, and she was confirmed to have neurosensory hearing loss and required hearing aids in childhood. Her mom said she always struggled with infections, and she easily was getting coughs and colds, and had adenoids removed. She required grommets in childhood. She had multiple episodes of tonsillitis. She had short stature, 148 centimeters. One of the geneticists, when assessing her, said she might have had a mild prognatism, she might have had low-set ears, mild pars cavus, but there was no peripheral neuropathy at that point. So she led a relatively normal quality of life until in her 20s, mobility became an issue. She started having balance problems, especially on turning. It was the main problem. When she was 27, she was referred to ataxia, a clinic led by a neurogeneticist. And they requested 100,000 genome project. So she was basically enrolled into this research project, which is now our whole genome sequencing. And it was pending because they received at that point in time hundreds and thousands of samples. The turnaround time was 2 years. She remained there to have the symptoms monitored. In the meantime, she developed hip problems. It was treated with steroid injections, but she did not respond to them. And when the 100,000 genome project has been reported, she was found to have 2 different mutations, 2 different variants previously described in a MAN2B gene responsible for alpha-monocytosis. Then she was referred to our center. We've done the functional studies. As you can see, there's our patient here. She had a classical ladder on the oligosaccharides. Her alpha-monosidase was reduced, and catechosidase was non-specifically increased. She had slightly ataxic gait, which obviously affected her quality of life. She became more dependent on her parents and occasionally started using wheelchair use and walking aids. And she required eventually hip surgery due to the left hip osteoarthritis. So in summary, I presented a case of an adult patient who developed symptoms of alpha-monocytosis over a period of 30 years until she was diagnosed at the age of 31. And since then, she started gradually developing other complications such as endocrine dysfunction. She has now secondary amenorrhea. She is awaiting cardiac workup for aortic regurgitation. She started developing swallowing problems and requires a multidisciplinary team's care. Now, since then, we embarked on a global international study looking for late onset and late diagnosed cases with alpha-monocytosis. And we identified 25 cases globally, 14 attenuated, so late onset cases, and 11 non-attenuated, so who had kind of severe phenotype, but the diagnosis was delayed for other reasons. And there were more female patients than male patients, and most of them were white, Caucasian. And as you can see, mean age of disease onset was 3.9 years, but in attenuated cases, it was slightly later compared to a non-attenuated group. And in terms of the age at diagnosis, again, attenuated group on average was diagnosed at the age of 33 as compared to 26 years in non-attenuated group. And as you would expect, attenuated cases were often compound heterozygotes. There was low consanguinity there. And this is only to emphasize, which we found quite relevant from the health economic point of view, that patients with attenuated forms, they can lead normal life. They can work, they can do low-skilled jobs such as voluntarily job. They may go to school, secondary school with support and education. We have 2 patients who were married, and one had a child, one is planning pregnancy. Now, again, this heat map, this is to emphasize that all these patients have a degree of learning difficulties in childhood, and they have a hearing problem, again, since childhood. But the black color shows the intensity and prevalence of these problems. So this is non-attenuated group here, non-attenuated, which is more severely affected. And you can see that throughout their life, some problems, this is per decade, so it's more black, meaning that most of these patients had complications with mobility, motor impairment, hearing problems, also they are prone to falls and so on, whereas the attenuated forms are more white, bright on this side, meaning the symptoms start, most of them, later in the 3rd, 4th, 5th decade of life. And again, when we ask the patients about the onset of their symptoms, again, you can see the top part is attenuated forms here, attenuated. So the onset of symptoms might have started here, but they were diagnosed much later. They die, pink is they die much later in their life, whereas the non-attenuated forms, everything is more clustered in the first 3 decades of life. So motor impairment, hearing problems, learning difficulties, wheelchair dependent, and other complications. What we found interesting among the attenuated group, there was a variety of different pathogenic variants, and they were equally spread across the gene. Whereas non-attenuated group, the mutations were most of them homozygous, and the mutations were clustered near the 3' and 5' ends of the gene. It's not clear why. As expected, those who had attenuated forms, they were seen over a period of years by various specialties, and there was a low index of suspicion of making a diagnosis of lysosomal storage disease. Whereas those who had non-attenuated forms, they were mainly seen by geneticists from the beginning. And there was a significant delay in diagnosis of 20 to 27 years in them. This is again to show that among the non-attenuated group, so patients with more severe symptoms, there were investigations and differential diagnosis considered as compared to attenuated forms, which were not really fitting into any group in many of these cases. This is to show that you may be already aware, but this is quite a relevant figure. Gaucher disease is one of the lysosomal storage diseases. There's a type 1, type 2, type 3, and there's also a type 1 childhood onset and late onset. And this graph is to show that the late onset cases have a residual enzyme activity, and this is the main reason why they present later in their life, and it's very relevant for all other late onset cases. Such as patients with MPS 3A and 3B we previously described with the Netherlands group. So MPS 3A, 3B, they are severe forms of mucopolysaccharidosis presenting in childhood with behavioral problems, and with no treatment, unfortunately, they may die quite soon. But the cases we identified, there were 12 different cases, most of them 3A, and they were diagnosed by whole genome sequencing because they were enrolled into certain panel tests, like our patient in a DDD study run as a research project, and also by metabolomics. And at diagnosis, 2 patients had retinitis pigmentosa, so a form of retinal dystrophy. 1 patient had cardiomyopathy, and 1 patient had neurocognitive decline. And 8 other patients were diagnosed in the pre-symptomatic phase by family screening. But at the last follow-up, the mean age was 47 years, so the eldest patient was 74, and 9 of them had retinitis pigmentosa, so the retinal dystrophy has progressed over time. More of them had a cardiomyopathy, and 9 out of 12 patients had normal cognitive functions. These patients have normal family life, profession, and they may be out there in the general population. Now, it leads nicely to another group of conditions which we identified and we have more and more referred to as now. It's a pathogenic variant in HD SNAT gene. So when nonsense mutations affect this gene in childhood, it manifests as mucopolysaccharidosis type C, for which there's no treatment at the moment. But there are milder mutations, missense mutations, which may be responsible for late onset, because these patients have residual enzyme activity, and these patients are often referred to us by geneticists or ophthalmologists, because patients present with macular dystrophy, they may present with retinal dystrophy, vision problem, tunnel vision, which affects their quality of life. They are not able to drive, and they are referred to us for functional studies. But urine GAGs, glycosaminoglycan, is completely normal in these patients, and enzyme activity is only marginally reduced. We also identified, we have a case, and we identified 2 other cases in the UK, and we recently published, patients with milder mutations in SMOOF1 gene. And this gene is responsible for multiple sulfatase deficiency. And there are only around 150 cases described globally. It's an ultra-rare condition manifesting as deficient or insufficient multiple sulfatases activity. But patients who present with this missense mutation, they have milder forms of the condition. And again, they were referred to us for systemic screening, looking for any skeletal problems, cardiac manifestations, hepatosplenomegaly, bone problems, and they don't have any, apart from the ophthalmic manifestations. So it's believed to be caused by hypomorphic forms of these genes, and there's research ongoing to understand it better. There's another case of ours, a patient with attenuated Krabbe disease. A patient who, so Krabbe disease, as you may be aware, is a globoid cell leukodystrophy. It's caused by GALC enzyme deficiency. It manifests as the cycosine levels are increased and myelin damage. So patients present usually with neurological presentations. And in childhood, it's a severe form. Now there's a newborn screening being introduced mainly in the US and some other countries. So more children will be diagnosed, and there's a therapy in development. But there were a few cases of attenuated Krabbe disease described in the literature. And when this gentleman presented to us, he was referred by the neurology team. He had progressive I want to play this. Oh. So when this gentleman presented to us in his 50s, he said his legs are weak, his legs are painful, his legs are stiff, and gradually it was getting worse and worse. But he had investigations between the neurology and metabolic teams, and his MRI scan showed classical white matter changes, also in the corpus callosum. Sorry, and he had corticospinal tract involvement. His CSF also confirmed high protein levels in his CSF as well. This gentleman had a brother who sadly passed suddenly, and he had a suspected diagnosis of multiple sclerosis, and this was one of the reasons why he suddenly died. But we cannot investigate it now, but we believed he might have had also Krabbe disease, because the clinical manifestations may be similar to MS. So, in conclusions, we know that there's an increasing number of adult patients with rare diseases, and there's a need for better services to support these patients, to diagnose them, to monitor and treat them accordingly. Transition service globally needs to be uniformed. We need better working groups, better guidelines, funding to make it kind of more sophisticated, let's say. And there are late onset forms with rare diseases, and we believe that there are patients with Pompe disease, with Gaucher disease out there in the community who are not diagnosed. And we know that we need to be more alert when we see a patient with thrombocytopenia, hepatosplenomegaly, and we need to consider screening for rare diseases. So this is the main message from me. Thank you. Any questions?
Thank you very much for this beautiful presentation. I'm interested with all these overlapping, attenuated, and complex phenotypes. What do you think about the role of the so-called
This is a very good question, a difficult question, because we know that, well, there are ethical dilemmas of screening patients with genetic testing. Well, as an example, let's say Fabry disease. I mentioned that at a time we may have 16 to 20 referrals, but there may be 3 generations of members of the same family affected with the mutation. And not always they want to be screened, to be approached, to be invited even to the clinic, especially younger people, because they don't want to be labeled with the condition if they don't have any symptoms. Plus, it affects their life insurance, their mortgage, if they have to declare that they have a condition, which they don't really have, right? So there are some dilemmas from ethical dilemmas, but also dilemmas in terms of from the patient point of view. And the question is, are we going to confirm that somebody has a mutation and treat them? What are we going to do with them? So this is the main problem in terms of the genomic newborn screening, which will identify some late onset cases. Because does it mean that this person from childhood up to adulthood needs to remain under the care of the adult metabolic team? Or we also introduced recently an initiative called PIFO, Patient-Initiated Follow-up, for patients like MCAT who live far away from us, but they are completely well. They don't really need any investigations. So there's a possibility that they will need to be kind of on our records without any need for being followed up long-term. We don't know. And we know that all these patients who have genetic testing done first, they will need functional studies. And as I show the examples, we do the clinical investigations, cardiac MR, and ultrasound of the liver, DEXA scan, the full workup to confirm, to look for any symptoms. And like the patient with Niemann-Pick B diagnosed at the age of 79. So it was not clear whether he had Niemann-Pick B or whether the enzyme was low as a result of ascites or advanced liver cirrhosis. But he also had mild heart valve disease. And you may question, is it related to Niemann-Pick B or is it age-related? And the same with respiratory disease. So, once we have the mutation, then we are looking for other problems. But we need to work with patients as well. They may not want to know whether they have any other symptoms if they are generally well. If we have functional studies, then we will have to move on and progress with the genetic testing. And it's very relevant for, there's a high index of suspicion, like let's say the lady with alpha-monosidosis. So if we suspect an LSD in her and she had enzyme activity slightly below reference ranges, the metabolic lab often comes back to us saying, repeat the sample. And we'll see if the next sample also shows slightly reduced enzyme. They don't rely on one result. But irrespective, we still have to do genetics. I'm not sure if it answers your question.
I work at the low platelet consultation, so to say. So every week we receive 2 or 3 patients with low platelets. So I, as a hematologist, my main diagnosis is just to screen things that are not hematological from things that are hematological, and immune thrombocytopenia is the main diagnosis, and it is it's a last resource diagnosis. But there are people who start having low platelets in their 40s, 50s, 60s, 80s, and you don't have anything else to pin it to. I mean, you don't have any other reason, and perhaps you have some kind of mild alterations in the liver enzymes or whatever for people who are otherwise perfectly healthy. Mm-hmm. So we perform genetic analysis focused on hematologic problems like dysplastic syndromes or aplasia or whatever, but only when we treat them only when they don't respond to classical treatments. So when should we, do you think we should start expanding our genetic testing, and also not only for hematological problems, but also to other kind of unknown genetic markers?
Definitely. If there's a young adult with, young, like a 19-year-old, we had a case, completely well, healthy boy, who had platelets of 117, so they were not even that low. But incidentally, he presented with gastroenteritis to A&E, and a junior doctor who was very thorough examined his liver and spleen, so he had hepatosplenomegaly, not just low-ish platelets. And then they asked for the consultation from hematologist, and hematologist was well aware of lysosomal storage diseases and Gaucher, and did the full screen. And yes, to answer your question, you don't have to wait until platelets are 50. Platelets can be just below the cutoff of 150, and if it's in keeping with hepatosplenomegaly, I would consider screening for Gaucher. So at the moment, there's another study we are doing with a northeast of England, where we are screening primary care records. And we worked out algorithms looking into iron or raised ferritin, low iron, hepatosplenomegaly, thrombocytopenia, and some patients with splenomegaly as well, so it's a second algorithm. But we looked at algorithms of different parameters and what the screening, the AI, which I mentioned, AI screening of the system, if they are going to identify any cases. Because we believe that there are cases with Gaucher disease, Pompe disease out there in the community. And it is possible that we may identify them by doing such studies, screening records. And I'm aware of similar initiatives, also screening biochemical records in Bart's Hospital in the lab in London, but also in the US group, looking at the not primary care but large health records in the secondary care in the hospitals. So there are similar initiatives because there's a strong suspicion that with the use of AI and the IT systems, we are able to identify these patients and treat them. The other thing is that patients don't have to have Gaucher disease. They may have a Niemann-Pick B as well.
Yeah. But I think there is of course, when the patient has, of course, evident hepatosplenomegaly, of course, that is going to do something. But most patients, most patients don't have a big liver spleen, and they only have maybe mild liver alterations that can be attributed to fatty liver acid, or perhaps they have been drinking when they were younger people, or whatever. So,
but you could do at least enzyme activity is cheaper than genetics and a better turnaround time. You have a metabolic lab here, right? Yeah.
Well, thank you for coming. I'm sure that now we are looking for atypical presentations and less phenotype or less classic phenotypes in our patients. And thanks for coming and your brilliant presentation.